I now present to you today's webinar entitled 2018 MIPS Cost Measures, Where Do I Begin? Presented by Ms. Donna Cohen, Deputy Director, Population Health, Alliant Quality. In compliance with ACCME guidelines, Ms. Cohen has no financial or other relationships with the manufacturer of any commercial service discussed in this educational activity. The objectives for today's webinar are to define a quality and resource use report and how to access the report, to explain the use of the data from the QRUR, to explain the specific data elements contained in the QRUR, and to identify where to call for help and resources.
Great. Thanks so much today for joining. Go on and get started with our topic today, which is 2018 MIPS cost measure. Where do we get started? We all know that cost is a factor under the quality payment program for 2018. So we all need to be focused on what we can do in our practices to make sure that we are competitive in seeing our patients along with the cost measure. So I always like to get started by knowing who my audience is. Y'all can see me, so you know who I am, Donna Cohen with Alliant Quality. So we'll give you just a moment if you can answer the polling question so I can determine who's in the room with us today. Great. It looks like we have mainly clinicians and administration in the room today, so thank you very much for participating in that poll. So we've already reviewed the objectives for today, so I'm going to go ahead and go to the next slide. And the next slide actually has another question for you guys to answer, and that is from a historical perspective. Did your TIN or the TINs that you are responsible for report PQRS data in 2016? Again, just trying to get a baseline of my audience to see what kind of experience you've had in reporting quality measures. And I am very happy to report that 100% of our participants participated in PQRS in 2016, so hooray, hooray. So what is a QRUR report? The 2016 QRUR report came out in September of 2016, and it shows by tax ID number the measures under your TINs for quality and cost, and it's used to calculate the value modifier for 2018. Now, the QRUR contains information on specific clinicians in your practice, and these are physicians, nurse practitioners, physician assistants, clinical nurse specialists, and certified registered nurse anesthetists. It is important to know that this is at the TIN level, so if you're responsible for multiple TINs, you will have a QRUR report for each TIN. This is 2016 data that is attributable to your 2018 value modifier adjustment. The data covers the time span from January 1st, 2016 through December 31st, 2016. And again, it's based off of claims as well as quality data. The claims data is data that you submit when you are billing for Medicare beneficiaries from your office, and that is at the TIN level. And then the quality data is also derived from your PQRS data that you submitted in 2016 under your TIN. All TINs nationwide that have at least one eligible professional that bill under Medicare will receive a QRUR report. So even if you did not report PQRS data in 2016, you will have a QRUR report, and it will reflect the fact that you did not report data in 2016. So how can this data be used for my practice? If you're like me, all this policy and procedures is very good, but what can I do with this data to really improve my practice operations? I want to briefly go over some of the things that you can do in your office when you review this data. First of all, it helps you understand the quality of care that's delivered to your patients or Medicare beneficiaries during the performance period compared to your peers. Now, the comparison to the peers is actually in your same geographic area. So, for example, if you're in rural South Georgia, you would not be compared to clinicians in the metro Atlanta area. It also assists in streamlining resource use and identifying care coordination opportunities. And we're going to talk about that very specifically when we go through some of the tables contained in your QRUR report. It may help you identify high performers in your practice. And you can use this data to negotiate with other payers, your commercial payers, because they all are measuring quality too. So if you're a very high performer compared to your peers, then this certainly would be a marketing strategy for you to negotiate higher reimbursement rates for some of the procedures that you do in your office. It also can target weak areas. If you may identify some low performers and some areas of opportunity for you to work on in terms of quality and cost of some of these providers. So let's talk specific about the value modifier. As I indicated, it applies at the TIN level to all physicians, nurse practitioners, PAs, clinical nurse specialists, as well as CRNAs who bill Medicare professional fee services in 2018. It's based on quality and cost performance in 2016, and it does align, thank goodness, with the PQRS program. It is waived for a TIN if at least one eligible professional who billed for Medicare services during 2016 participated in an ACO or a next-gen ACO generation model. Many of you, I know, do not participate in these. So the point here is there are some practices who are waived if they are participating in some of these innovation projects from Medicare. 2018 is the last payment adjustment year under the Value Modifier program because you all know that we transitioned in 2017, which will be reflected in your 2019 payments under the Quality Payment Program. So 2018 will be the last adjustment year for the Value Modifier payment. And as I indicated, it is being replaced by the merit-based incentive payment system under the new Quality Payment Program. And if you have not had an opportunity, and I'm sure you have heard if you've been on any of these webinars with Georgia High-Tech, the website qpp.cms.gov, then I strongly encourage all of you to look at a wealth of information and resources concerning the Quality Payment Program at that website. So I'm going to give you all an opportunity to participate again. I want to know what your experience has been with your QRUR report. Have you reviewed and you understand your report? I have reviewed it, but I do not understand it. I'm having difficulty accessing my report, and I've never heard of a QRUR report. Again, this information certainly helps me focus the presentation that would be much more useful to you, so I appreciate you participating in these polling questions. Well, it looks like we've got about 40% that either have had difficulty understanding or have had difficulty accessing. Thank goodness everybody has heard of a QRUR report, which is great news. And about 60% of you have reviewed your report and understand your report. Hopefully, as I go through some of the tables contained within the report, you will gain additional information on other ways that you can use the data that is contained within these reports. So this is a very busy slide, but basically what I want to point out here is there are two categories under the Value Modifier Payment Adjustment, and that's Category 1 and Category 2. Category 1 is basically those TINs that will not have a negative adjustment. They successfully reported PQRS data, and they will not have a negative adjustment they will either have an upward or a neutral adjustment, and this upward adjustment can be up to times 3 times the adjustment factor. Category 2 are those TINs that will have a negative adjustment, and depending on the size of the TIN depends on the adjustment. If you have a TIN with fewer than 10 eligible professionals or no physicians, for example, all nurse practitioners, then you would have a negative 1% downward adjustment. Or if you were in a TIN with 10 or more eligible providers with at least one clinician or physician, you would have a negative 2% downward adjustment. So this is important when you look at your QRUR report. It'll tell you which category you fall under, whether it be Category 1 or Category 2. So when we look at the quality tiering approach for the QRUR report, as I indicated, there's a maximum upward adjustment of 3, and it's multiplied by an adjustment factor. The adjustment factor for this year is 6.6%. Now that adjustment factor changes every year because it depends on how many people fall within that high positive adjustment, because this is a budget neutral program. So it's hard to know exactly what the adjustment factor is going to be until we know how many people fall out into each category. This table that you see on the bottom right indicates the 2018 value modifier adjustments under the quality tiering for Category 1, regardless of the size of TIN. So remember I said a Category 1 is those that would not receive a negative adjustment. So based off of where you fall under cost and quality, you can follow the grid to determine if you would have a neutral adjustment or a positive adjustment. And you'll notice on the far right-hand side, if you have low cost and high quality, then you would get that positive 2% adjustment factor. And I'll talk about how you can get the 3% a little bit later in the presentation. So this is just an overview of the actual report. There is a cover page that indicates whether you received a negative or a positive adjustment. And then there's several different exhibits, and we're going to go through each of the exhibits in this report. Followed by your performance of quality measures, which is Exhibit 2, 3, and 4, and then your performance of your cost measures, which is Exhibit 5, 6, and 7. So where does the cost data come from? There's actually 6 cost measures that are calculated using claims. This is nothing that you have to submit additional data on. It is the claims that you drop on your Medicare fee-for-service claims. This is not your Medicare Advantage patients. This is only your Medicare fee-for-service claims. So the cost data comes from the per capita cost for all attributed beneficiaries. And this is all providers, not just the services that you are performing from your office. The way beneficiaries or patients get attributed to a TIN is by the number of primary care services that are conducted by that TIN. So if you're a respiratory, or if you're a pulmonologist and you are providing the primary bulk of primary care services to that particular patient, then you could be attributed patients because you are provided primary care services to that patient. And you'll see the breakdown of this a little bit more in the tables as we talk about it throughout the presentation. Another cost measure is the, could we go back one slide? Okay. Another cost measure is the per capita cost for beneficiaries with specific conditions, and those conditions are diabetes, COPD, coronary artery disease, and heart failure. And again, this is cost for all providers. And then last but not least, the Medicare spending cost per beneficiary. And this is the cost of inpatient hospital stays 3 days prior to admission, 30 days post-discharge. and this is for all hospital stays for those patients that are attributed to your TINs. So just to get a feel for how many of you have had a neutral, positive, negative adjustment, or are you unsure? Thank you for participating. We've got 66% with a neutral adjustment and 20% with a positive adjustment, which is great news. And then we've got about 40% that is unsure about whether they have an adjustment or not. So this is very typical when we go through the percentages of adjustments. Later on in the presentation, you'll see that the majority of folks across the nation are receiving a neutral payment adjustment. So let's dig on into the beginning of the QRUR report, and it starts off with a cover page. And you'll see a scattergram that shows where you are in relationship to all the other TINs in your area. Each of the blue dots actually represents a TIN. So for this particular TIN, you see that they fall in that upper right-hand quadrant, which is the most positive place to be, which is high quality and low cost. So on the cover page, you'll see what the TIN number is, what the practice name is, as well as the performance period. And remember, I indicated that this was January the 1st, 2016 through December 31st, 2016 for the performance period, which the payment adjustment becomes in 2018. So on this slide, you will see how the value modifier applies to your TIN. In this particular one, you see in the highlighted area, at least 50% of the eligible clinicians under this TIN reported PQRS data and avoided the 2018 PQRS payment adjustment. So the quality data was there for them to extrapolate in doing the analysis for the QRUR report. Now, I talked about there being a additional 1% adjustment factor. If your clinicians are seeing patients that are considered high risk, then there is an additional adjustment factor that you can receive of 1% if 75% of your clinicians are considered high risk. And this is very important when your clinicians are coding their claims, because Medicare takes the coding information and projects what the cost of these beneficiaries would be based on their severity of illness. So if you're only coding, let's say, a diabetic patient with diabetes, when really they have diabetes with retinopathy and perhaps neuropathy, then that cost, attributed cost to that beneficiary is going to be much lower than the actual picture of the patient with the diabetic with neuropathy and retinopathy. So Exhibit 1 is really just a breakdown of that grid that we saw in earlier, and this tells you in the highlighted area here that this particular TIN has high quality and low cost, and they will receive a 2+ adjustment times the adjustment factor. So the 2016 value modifier adjustment, and we just answered this. I'm sorry I put this in as a duplication, so we can just move forward and not review this polling question. So how does the high-risk bonus factor adjustment apply to your TIN? So remember I said that if your patients are, quote, sicker than other patients in your peer group, then you could qualify for a 1% additional high-risk bonus adjustment. And this slide here shows, or this exhibit here shows that the patient population for this TIN was not above that 75th percentile for all beneficiaries nationwide, so they would not receive that additional high-risk bonus adjustment. If they had, then they would have had that positive 3% adjustment times the adjustment factor. So Exhibit 2, again, is just a breakdown of where you rank among other TINs as far as quality. low, average, and high. If you fall in the average area, you're going to get a neutral adjustment. If you fall in the low, you will get a negative adjustment. And if you fall in the high area, which is greater than 1.0, you're going to get a positive adjustment. So let's talk about what quality measures are used to calculate the quality composite score. There's actually two measures. It's the quality measures reported by 50% or more of your eligible professionals in your TIN who avoided the 2018 PQRS payment. So those clinicians that successfully reported PQRS, it uses those PQRS measures that were reported in 2016, along with 3 outcome measures that Medicare calculates from your Medicare fee-for-service claims submitted in 2016 to the beneficiaries, again, that were attributed to your TIN. And we'll talk about those 3 outcome measures a little later on in the presentation. So Exhibit 3 is a breakdown of your TIN'S Quality Composite Score. And this, again, comes from your PQRS data. So you can see here the number of domains when you reported your PQRS. This particular TIN reported 4 under 4 domains. And if you look at the bottom grid in the center, the number of measures included in each domain. You see the domain to the right, and then those measures that were reported successfully under each of those domains, and then what the domain score is. The gist of this screen is looking at that quality composite score that's highlighted there. And this particular TIN's composite score for quality was 1.32 compared to the benchmark of 0.3. So in terms of quality, this particular TIN scored way above the benchmark, which put them in that positive 2% payment adjustment area. So Exhibit 4 actually breaks down this PQRS data a little bit more and shows you the specific measures. For example, this was colorectal screening area measure, what the performance rate is for your TIN, which was 85%. And then over on the far right, you see the benchmark, which was 67.32. So as far as the quality composite score, the graph at the top, you were at 1.21, which again is above that 1.0, which would mean that you would have a positive adjustment. This is those other domains that's calculated from claims that are submitted on your behalf to calculate your quality composite score. If you look at the bottom grid, it talks about those acute conditions that I talked about, as well as the chronic conditions, and that third measure of all-cause hospital readmissions. So these are conditions that we would hope would, these acute chronic conditions would be conditions that we would hope patients would not be hospitalized because they would seek intervention in your office earlier. So we think about access to care and making sure these patients were getting in early that have a UTI or dehydration and bacterial pneumonia that typically would not require a hospitalization if they were treated early. So you see the performance rate in the middle of the grid here for this particular TIN, and then on the far right what the benchmark was. In this particular slide, the lower the performance rate is, the better, because you want less hospitalizations per 1,000 beneficiaries. So this particular TIN did really well in that area. And then the second measure is those chronic conditions. So how well are you managing these patients from an outpatient perspective? Again, you see the performance rate along with the benchmark for each of these chronic condition composite score. And then last but not least is that all-cause hospital readmission rate. So patients that were admitted within 30 days of discharge, and again, the performance rate against the benchmark. So you can see in all of these areas where your TIN ranks to your peer group. Let's move on now from quality to cost. And like I was just indicating, the lower the number for cost, the better. So this particular TIN fell in negative 1.1 for their cost measure, which means, again, that positive payment adjustment. So where are these cost measures coming from? We talked about where the quality measures are coming from. The cost measures are coming from those patients that are attributed to your TIN and the beneficiaries with diabetes, COPD, coronary artery disease, heart failure, and that Medicare spending per beneficiary, which again is the hospital cost of those beneficiaries attributed to your TIN. So we see under the cost the number of domains that are included, and the domains are listed here at the bottom of the screen. That cost for all beneficiaries as well as the cost for beneficiary with specific conditions. What this particular TIN's domain score is compared to the benchmark. Again, the lower the number, the better. So the information used to calculate the TIN's cost performance score is shown on this slide here, where it's the actual cost of the per capita cost for all attributed beneficiaries as well as the Medicare spending per beneficiary. So you see per capita or per episode cost compared to the benchmark. So you can see here what your total cost of care is, which is that per capita cost, versus your hospitalization cost, which is that Medicare spending per beneficiary, and how you rank toward your peer group. So here we get into the tables of the QRUR report, and the first table identifies the physicians and non-physicians that were identified in your Medicare enrollment. This information comes from your PCOS data. So if this information is wrong, then you really need to look at your PCOS data and update your PCOS data to make sure that all the clinicians that are practicing under your TIN are listed there. It tells the clinician's NPI, their name, whether or not they are a clinician, whether or not they were eligible to or subject to the 2018 Value Modifier, as well as what type of clinician they were, and then how that information was verified, whether it was from PCOS or from your billing data, and then the last claim billed under that TIN. So I would encourage you to look at this, and if you've got some claims that were billed early in 2016, you can see maybe those clinicians are not attributed to your TIN. So this is probably one of the most important reports that you can get from your QRUR report. You can analyze this to see the beneficiaries that are attributed to your TIN. So, you know, especially if you only see a patient once or twice, you can tell that maybe they're not coming into your office as much as they should. So that could be some opportunity for some outreach measures. It also, in this report, has the HCC percentile ranking, and this is a hierarchical condition coding percentile ranking. And this information comes directly from how clinicians are coding claims and making sure they're coding to the highest specificity as possible. And that I mean like the diabetic case or the diabetic patient that I shared with you, making sure that all comorbidities are listed on these claims, and these comorbidities have to be listed every year. Many clinicians who are doing this really well use the annual wellness visit as an opportunity to make sure that they are dropping all of these chronic conditions on these patients' claims annually. If you do not drop them annually, one time is not enough, and I'm sorry to be the bearer of that news. You would think if you dropped it one time, CMS would have it, but that's not the way it works. It has to be dropped every year for all of these chronic conditions for your patient to be considered a high-risk patient. This information can actually be downloaded by Excel, and you can sort these to see your patients that have higher rankings and those that have lower rankings. It can also be sorted on the date of service on the last claim and the number of primary care services provided. So if you've got a patient that's only had 1 or 2 primary care services provided, again, that may be an opportunity for some outreach to that patient. Just additional information on beneficiaries attributed to your TIN. This slide is very important because it not only shows you the services that are provided by you, but it also provides services provided by others. So you can see if specialty care providers are providing primary care services on your behalf. So again, that might be an opportunity for some chronic care management and making sure you're directing these patients to the right services. Again, this can be downloaded in Excel and sorted, so it can provide you a lot of information if your electronic health record does not have the capability of doing this. Table 2B shows you the hospitals that your beneficiaries were admitted to that were attributed to your TIN. So it shows the number of stays that patients stayed in the specific hospitals that they attended, and as well as the percentage, so you can see where your patients are going to for hospital stays. This slide, again, is very, very useful, or this table is very useful. It shows the hospital admissions, the actual beneficiaries, when they were admitted, and what hospital they were admitted to. So, again, very useful for chronic care management to make sure that you are reaching out to these patients that had multiple hospital admissions and implement some chronic care management for those patients, hopefully to avert as many hospitalizations in the following year. Table 3B is the per capita cost by category, and I know this is very busy. You probably can't see it very well, but this actually breaks down the claims by category of services into surgeries, durable medical equipment, medical supplies, specialists, so you can see what percentage of your cost is coming from each of these services compared to benchmark. So if a lot of your patients are seeking services through specialty care providers that's higher than the benchmark, then that would be an opportunity for you to reach out and hopefully lower those costs and try to keep those patients and treat them in-house as much as possible. So this is cost of service provided by your TINs and other TINs. So this is very, very transparent information where the cost of care is attributed to your TIN as well as other TINs that provided services to these patients that are attributed to you. It breaks it down by types of codes. So your EIDM codes, your minor procedures, your ambulatory minor procedures, along with some others that we'll see on the next slide. So these are the additional breakdown of cost of services. You've got outpatient physical therapy, inpatient hospital services. So you can see where your dollars are, or where the dollars that you're spending are going for these additional services provided not only by your TIN but other TINs in your area. So Table 7 is the individual professional performance on the 2016 PQRS data. So you probably, if you, excuse me, if you have pulled your PQRS feedback report from 2016, this is much like the data that you would see in your PQRS feedback report. So many of you have probably already accessed this information. So for those of you who've had a problem accessing your report, you access your report from the CMS portal, and it's available for authorized individuals, solo as well as group practices. Now that authorized individual is the key to that. So if you've not been set up to be able to access these reports, on the next slide I will show you how you can get access to an EIDM account to access these reports. So you must have an EIDM account. If you don't know that whether you have an EIDM account or maybe somebody else in the office is attributed to that TIN and has access to that EIDM account, you can either email QualityNet at the email address you see listed on the screen, or you can call the number and provide the name and the number of the TIN, and they will actually look this up and tell you who has access under this particular TIN. If you've never had an EIDM account for a particular TIN, you can sign up for a new EIDM account or modify an existing EIDM account to add to the correct role every 60 days. And again, this can be done on the CMS portal. So to access your report, again, the link here to be able to access your report, and you need to log in. If you need instructions on an EIDM account and accessing the 2016 QRUR report, the link that I have provided here, which is also in the information in the handout section, you will be able to click on this link and get step-by-step instructions on how to set up your EIDM account. I always recommend, if you're having difficulty, to email rather than call. Most email is answered within 24 hours, and then you have a document that you can refer back to if you ever have any questions on what you were told of what was said. There was a time period that you could request an informal review if you did not agree with the information that you viewed on your QRUR report. I will tell you I've worked with a couple of practices whose information was wrong on their QRUR report. It was their PQRS data that was wrong, and that information was, an informal review was requested, and the QRUR was adjusted, and the negative adjustment was dropped. So if you ever feel like that in looking at either your PQRS data or your QRUR report, that the information is incorrect, then I strongly encourage you to file what's called an informal review. There is a specific time frame that these informal reviews can be filed for, and for the QRUR report, it ended December 31st, 2017. So I wanted to share with you some results that I thought was very interesting about the number of clinicians that received a negative and positive adjustment. As I indicated, if we look at the grid for 2018, the majority of clinicians received a neutral payment adjustment, close to 75%. A small percentage received that upward payment adjustment of 1.8% of clinicians. And then, unfortunately, 25% received a negative payment adjustment because they did not file their PQRS data. You can also see the trend from 2015, 16, and 17, and you see that compared to 2016 and 17, there's been a little bit of increase in those clinicians that received a positive adjustment. So last polling question, I have reviewed my QRUR and have used this data to make positive changes in my office operations. CMS asks us for feedback from the field all the time about if this data is useful. So this is a great opportunity to share with me if this information contained in your QRUR report was useful. And if you have any suggestions on information that's not in there that you think would make it better, or if you found this information not useful, if you could type in chat so I can take those recommendations to CMS and let them know what the people in the field are really thinking about this report. So actionable items. I always like to end the presentation with things that you can do, and that hopefully you've learned some things from this presentation that you can take away and implement in your office. If you've not downloaded and reviewed your QRUR report, obviously that's the first thing you need to do, and making sure that you have an EIDM account with the right access to access your QRUR report. Review your quality measures and look for areas of improvement. What areas are you scoring low in and what's some opportunity there? Review your cost per beneficiary and look for opportunities. use those tables, download that information into an Excel spreadsheet, sort it and manipulate it so you can make positive changes in your office based off of the information that you're able to glean from looking at that data. If you don't have any protocols in your office where you are encouraging all the clinicians to practice to evidence-based guidelines, I certainly encourage that. Also, if you've not implemented the Choosing Wisely program, which really looks at avoiding unnecessary tasks, so if you've not implemented that in your office, that's something to consider as well. And then chronic care management. I can't speak highly enough about chronic care management, and me talking with practices across the state, they have really found that chronic care management has not only benefited their patients, the quality of care that the patients are receiving, but it also has been an additional revenue stream to the office as well. So again, where to call for help if you have QRUR or value modifier questions. This is not information on how to access the report, but this is information if you have questions about the report and you do not understand some of the specifics within the report. This is the contact for that. So you see some links here to email addresses that you can get assistance. We are funded by Medicare. ga-hitec is our partner in Georgia that helps us support clinicians who need help in successful reporting under the Quality Payment Program. So if you email either one of those two email addresses, we will make sure that we connect you with someone that can assist you in making sure that you're reporting your quality measures in 2017 successfully, and then look forward to working with you on reporting your 2018 measures. At this time, I will open it up and see if there's any questions in chat.
We have a question from Simi, and the question reads, for the new MIPS cost performance exclusive to Medicare beneficiaries?
The cost performance is for the PQRF quality is the all payers, but for the cost, it's for claims received from your Medicare Part B spending.
Okay, and we just want to clarify, and I know that you mentioned this before, but how can groups or solo practitioners request an informal review for the 2018 Value Modifier calculations?
The deadline for the informal review for the 2018 Value Modifier ended December 31st, 2017. So unfortunately, it is past the deadline, and it's impossible to file an informal review at the current time. That would have had to be done before December 31st, 2017. And there you would have contacted the help desk. There was a particular link that you would have accessed and filed an informal review.
Have another question from Laura. So essentially, Laura says, as an orthopedic practice, our patients do not understand why our physicians are adding comorbid codes to their office visit notes that have nothing to do with their care at our office. For example, if a patient presents with a wrist fracture that has morbid obesity or COPD diagnosis listed, etc. Is there any advice?
My advice to you is to explain to those patients that those comorbid conditions can affect them with mobility. If they're diabetic, they can affect their healing process. So there's just about every chronic condition affects any type of procedure that you have. So if you want to email me offline with a specific case, then we can certainly talk through that. But I am pretty sure that just about every chronic condition is going to affect procedures that a patient may have in any specialty office. And when you talk about COPD, you know the O2 supply to the tissues can affect healing. Now, patients probably don't understand that, and they would have to be explained that, but it would factor into their cost measure. They would just be at a higher risk, and it's important for, I would just explain to them that it's important for Medicare to know what their overall condition is that can affect their ability to heal quickly.
Thank you very much. Ms. Cohen, could you please provide any resources or spaces where, or places where a practitioner can go to access content regarding the implementation of chronic care management?
I have an excellent resource that I can email them, or if you just Google CMS Chronic Care Management, there's a great toolkit that CMS has on implementing chronic care management. I have a toolkit as well. So if you'll just back up one screen so they can see the email address that was listed on the screen, if you would email that, I can email that. I will get that and send that to you as well.
For those who are on the call, if you're interested in content regarding the implementation of chronic care management, please feel free to email the email addresses which are currently on the screen. Additionally, the webinar presentation and the resources discussed in today's webinar can be found in the lower pods under the webinar presentation. We encourage you to still submit questions to Ms. Cohen. Well, actually, we are now at the top of the hour. Ms. Cohen, thank you very, very much for an extremely informative presentation.
Thank you so much. And everyone, please feel free to reach out. We are funded by CMS to assist you, so be happy to answer any questions and work with you as much as possible. Thanks, and have a great day.